Great, thank you. So, yeah, thanks so much, Sherelle. And I'm really glad that you're all here with us today for this conversation. I see a lot of familiar faces and some new faces, which is exciting. Just to give an introduction of myself. So I'm a longtime educator at Beckley Academy. I'm the head of education. I was a high school teacher of students with learning differences for many years. And then before I came to Beckley, I was the um, director of education at Sensory Motor Psychotherapy Institute for 12 years. I'm really passionate about the neuroscience of learning, particularly the significance of social engagement in learning, and those parallels between learning and therapy. And some of those things we'll get to touch on today in our conversation. So the theme of our conversation today, as Sherelle said, is deepening into experience. So we're talking about holding space in non-ordinary states. We're going to take a deep dive into the elements of psychedelic assisted therapy dosing sessions, like non-directive approach, inner healing intelligence, and therapeutic attunement and social engagement. We're really looking to talk about those things that are happening sort of beneath the surface and beyond words. As well. We have two people that I'm continuously inspired by, that I love working with here, Karina and Danielle, who are both BA faculty, and we'll take a moment for them to introduce themselves. And Karina, if you'd like to go first, go ahead.
Sure. Thank you, Deb. Hello, everyone. Thank you for being with us here today. Before I get started on talking about my professional roles, I am going to take a lesson from Danielle, who's here with us today. She always reminds us to start with talking about the roles outside of who we are professionally. And so I'll begin by saying I am a mother to 3 beautiful adult boys. I'm a sister, I am a daughter, a partner and friend. And more than anything, I am a student of life and a student of divinity, which has really brought me to psychedelic medicine work. So yeah, I'm a human being before I'm a professional, but I am also a licensed psychotherapist. I'm an educator and clinical researcher here in Los Angeles. I have been providing psychotherapy for over 18 years in a variety of settings with a diverse population of patients and clients. After about 13 years of providing traditional psychotherapy, I began pursuing alternative therapeutic modalities, not only for the clients that I was serving, but for myself as well. Life was getting interesting and difficult as I was raising my boys in a complex world. And so I began extensive therapeutic and spiritual training, incorporating psychedelic medicine into my work, personally and professionally. I ended up completing a certificate in psychedelic assisted therapies and research from CIIS and MAPS in 2019, and have since completed training specific to delivering psychotherapy using MDMA, ketamine, psilocybin, LSD, and very recently 5-MeO-DMT. And I am pleased to have received training specific to internal family systems therapy, if anyone is familiar with that, specific to psychedelic psychotherapy, in some cases directly from Richard Schwartz, which was quite an honor. I am senior clinical program psychotherapist and advisor at Pacific Neuroscience Institute in Los Angeles, where I facilitate psychedelic medicine sessions using psilocybin, LSD, ketamine, and 5-MeO-DMT. Aside from my faculty roles at Beckley and CIIS, I train and supervise therapists delivering ketamine-assisted psychotherapy in clinical settings and maintain a private practice here in Los Angeles focused on treating depression and anxiety, codependency, intergenerational, and religious trauma. Thank you.
Hi, everyone. Thanks, Karina. It's such a joy to be up here with these two favorite people of mine. Similarly, I'll introduce myself with some of my relationships first. I'm a daughter, I'm a sister to 2 brothers. I'm an auntie to a 5-year-old named Jackson. I'm a lover, a partner, a friend, a bestie. I'm a poet and a Sufi, and an artist of various modalities. And I love, and I express a lot of my love through my role as a psychotherapist. I'm currently in private practice, completely offering ketamine assisted therapy and psychedelic integration primarily, as well as harm reduction psychotherapy. My psychotherapy lineage is primarily harm reduction oriented. So I like to say I work with drugs full spectrum. Folks who are struggling a bit, maybe in a more chaotic relationship with their drug use, and folks who are working with drugs to experience spiritual emergence or awakening, and I get to support them in that process. I'm currently a supervisor and clinical consult for Alchemy Community Therapy Center, as well as CIIS, and a facilitator here with Beckley. And I've been really enjoying my time.
Thank you both so much for introducing yourselves. We'll get started. You obviously bring a wealth of experience, both of you, to this topic. And I want to start with the concept that therapy doesn't happen in a vacuum. We know that there are a number of influences that impact the client, that impact the therapist, that really comes into medicine dosing sessions, which is what we're focusing on today. So I think, Karina, if we could start with you, can you let us know from your perspective what all of those influences are that come into the room during dosing sessions?
I think we can think about the influences as, first off, the relationship between the facilitator or therapist and the participant in the process. And so first things first, we bring ourselves, right? So our respective histories, either with that particular participant or with the work itself, and our role as facilitator and psychotherapist. We're also bringing our respective expectations to the process, right? So what do we expect is going to happen? We often ask our participants to be free of expectations during this process, but I think it's really important that we recognize that no matter how hard we try, we are bringing those expectations in. We're bringing our desires. Specifically, I like to share with participants, my desire is for you to meet your intention. And your intention is often to get better or to feel better or to be free of some of the mental health symptoms that have brought you to this moment. And so we are also bringing our intentions, right? We ask folks to specifically verbalize their intentions a lot of the time in these sessions. And so I'm eager to hear about what their intentions are and listening for what my intentions are as I hear those. We're also bringing our mood, right? We're bringing how we're feeling that particular day. And these all play a role in what we call set and setting, which are both really important aspects of this work, right? So our set, our mindset, how are we feeling? How are we thinking? How is the participant feeling and thinking? And the setting, the environment that we're in. What kind of environment or container have we created together? So see, these are some of the things that we bring into the medicine session, and it's one of the reasons that it's so important that we are aware of and honest with ourselves about how we are feeling, how we are thinking, and specifically what we're bringing into the room.
Thank you. Danielle, how about you?
Yeah, a couple things to add. That was such a great answer. Things that are just popping to my mind because you can answer this in so many different directions. One is our like stigmas. I think we're bringing sort of like our preconceived notion about a lot of different things into this space. One of those things being psychedelics or drugs in general, what our relationship like is to that word historically, relationally within our family systems. We're sort of bringing that sort of like egregore into the space and sitting with it in relationship to the therapist on what it means for us to be in relationship to it now. Similarly, we're bringing in our relationship to therapy and what that means or what it's like to be in that receiver of support or help role. So the vulnerability is really present. And then on the kind of more positive side, I was thinking of how with my clients a lot, we're talking about like ancestral and intergenerational trauma and wisdom and joy. So when I first heard this question, I actually thought of the like way in which we bring our ancestors into the room. So we're bringing in our lineage and everything that they carry and that they would like to work with also into our intentions, like Karina said.
Yeah, and you both brought up things that we talk about in our course throughout it, which are there's, Karina, you brought up sort of the self, the therapist self, right, in relationship to the client. And Danny, you kind of brought up these systems, right, on the outside that are influencing. I'd love it if you could share sort of an example, a clinical example of when either or both one of those relational or self influences came up with a client, or one of those bigger systems sort of that influence came up with the client. And whoever has the example first, feel free to start.
I guess the one that comes up right away is on that drug topic. So, even folks who are coming into psychedelic therapy with, complete autonomy in choosing to do this particular modality, some latent stigma can be present. So I've had a client, for example, who was going through ketamine therapy, and it wasn't until their like second or third ketamine session where when they were in the dosing session, had this emergence of shame surrounding what does it mean that they're having to use drugs in order to heal, and shame surrounding like almost like a comparison to other people, like why do other people figure it out but not them, and they have to use drugs? Does that make them know better than, I think their example they used was like the people on the streets in the Tenderloin in San Francisco. And so we really had to work with that in the middle of a dosing session of like, okay, so what are some of the feelings that are surrounding the folks that are using drugs in the Tenderloin, as well as what sort of like just like trauma is there in relationship to people who use drugs, maybe even in the family system, and do a lot of like reframing and reflection, and like working with the like, going back to like, what does ketamine do, and how is it working in your brain, and what does it mean to kind of be in relationship to this medicine as a tool, as an ally, as a support system. How can we still bring it back to you and your inner healing intelligence, that this is you that's doing the work, and the medicine and the therapy gets to support that. So that's one of the larger level ones I could think of.
Danielle and I talk a lot about not just liking the folks that we work with, but actually loving the folks that we work with. And I think it's a good opportunity to talk about how important it is to care deeply for the individuals for whom we are facilitating these very powerful experiences. And so some of the most powerful relationships and sessions that I've had in this realm include folks who have struggled with and really been traumatized by religious or spiritual trauma. And, this isn't just a specialty of mine. This is something that I've been affected by myself. And so when we bring this level of, knowing and care and passion and love for the work and for the participant, it comes through in healing. It's very apparent to me, and also to the participant, that they are being heard, they're being cared for, and they're safe in these environments. And so, what, in that case, what am I bringing? I'm bringing my passion for the work. I'm bringing my own personal experience, albeit therapeutically, but they can feel it. So it's really a tremendous amount of care, love, and respect for the process, I think, that really serves to create a strong healing container.
Yeah, thank you. And you both touched on a topic I'd like to discuss next, which is inner healing intelligence. It's a phrase we hear often in the field. It's a little bit amorphous in sort of what it means. I think it can be, Danielle and Karina, you both described sort of like it can be either positive, valence, or negative valence, depending on what emerges in that moment. I'd love to hear, maybe we'll start with you, Danielle, what does inner healing intelligence mean to you? How do you see it show up in your work? And then how do you navigate it with the client?
Great. Yeah, it's such an important topic in psychedelic therapy. I don't think I mentioned this in my intro, but this is from the MDMA training from MAPS, and then you can apply it pretty much everywhere. But really, the concept is that when a human being falls and cuts their arm, they have this wound, but they and they like protect it in some certain way. They provide the conditions in which it is to best heal, and then it heals. The intelligence of the body actually knows how to heal it. We don't actually have to like do anything other than clean the wound and protect it and like pay attention to it. So it's the same exact concept occurs within like a emotional or a social or psychological framework, spiritual framework, where you're creating the set and setting in which the conditions to heal are most supported. And with clients, I'll constantly point to it because there does seem to be this sort of like stuckness or this positionality of like, I'm not the one who makes me heal. Either the therapist is the one who makes me heal, or there's something out there externally that makes me heal. So in my practice, we're doing a lot of like decolonial work, where we're pointing to like, those are icky concepts that we get from like colonialism or capitalism, that there is something that you need to go get so that you can heal. And instead repositioning, and even working with the transference there, where it's like, well, all I'm doing is providing you the space and finally attuning and working with you so that the space and the conditions are set so that your body can naturally work with this material.
I like to remind participants as well that just like a physical wound, you may often require professional help if the wound is significant enough or has been ignored enough so as to become infected or gangrenous, right? And this can happen with mental health conditions as well. We can be injured or wounded or traumatized enough that we would require professional help. And so there's no shame in that. We would never shame somebody for pursuing professional help or going to a doctor or a specialist for a physical wound, and the same is true psychotherapeutically. I think something one way that I like to use this inner healing intelligence, especially because our work is often discrete because of the nature of psychedelic work at this point, at this juncture in the US and other places as well. We are not often allowed to use these medicines outside of clinical trials, or we are allowed to use it in discrete work with ketamine. So I like to remind people that since our relationship is discrete, in other words, it's short term a lot of the times, whatever comes up first is what we will attend to first, right? So, some people come to me, with 20 or 30 years of therapy under their belt, because I often serve folks who have treatment-resistant conditions. And so I explain to them, there is no way that in a 6-week ketamine-assisted psychotherapy program or protocol, I'm going to be able to uncover all of that complexity. And so how will we deal with that? We will trust the inner healing intelligence, and we will work with what comes up first, knowing that what comes up first is coming from you and for you.
Yeah, thank you both. And I think that really goes well into our next prompt, which is about a non-directive approach. And, non-directive is sort of maybe a misnomer, right? It connotates like a hands-off, not providing guidance sort of definition. And we know that that's not actually how it plays out. And I'd love to hear from each of you, what does a non-directive approach really mean to you in this work? How do you offer that support to your clients without interfering with that inner healing intelligence? Yeah. Maybe Karina, you want to go first?
So, I think I kind of started the idea that we are respecting what comes up first, and we are recognizing that that is what's coming up for attention, right? And so utilize this kind of curious and compassionate approach without inserting my own agenda. And that can be different than traditional psychotherapy. In fact, in traditional psychotherapy, we may outline in our treatment goals the agenda, and I may be speaking a lot more than in medicine sessions. And the reason for that is that I'm curious and I'm listening for what is emerging when the participant and the medicine come together. I have very little to do with that process aside from being supportive and maybe perhaps shining a spotlight on some of the areas that are emerging. And so what we're really doing in this work is watching, we're listening, we're asking curious questions in an effort to find out what happens when the participant and the medicine meet.
Yeah. Yeah, it's an interesting term for what we were kind of speaking to. It's like this space holding, or this orchestrating, or this containment and attunement. The way I feel it being expressed in the room, it actually does seem to begin in the preparation phase, where you're sort of letting folks know that, when we get to the dosing session, it's going to look a bit different. It's usually at least for ketamine sessions on my end, is 3 hours. They're 3 hours long. And in preparation, there's this process of letting folks know that at different doses, you're going to have a different shape of psychotherapy. So at like a lower ketamine dose, it would be more like psycholytic. So I'll describe it almost as like therapy on steroids. In a medium dose, you're kind of entering or edging against that psychedelic experience, where I'll be more like hands off and letting the ketamine sort of enter like a depth of relationship, and helping support the client turn inwards is like a non-directive approach, where folks will kind of be used to the externalizing and processing of psychotherapy, and instead we're directing them towards inner healing intelligence and towards the emergence of their own symbolism. And then in a larger dose, there's like more of an intense psychedelic experience. And there are some sessions where I'm pretty much the whole time just on my knees next to somebody as they're in that space. And as little moments sort of emerge and they have eye shades on, then we're sort of like working with the expansion of that imagery or that material, the somatic release. We're sort of like encouraging it, scaffolding it. It feels a lot more like an energy work session, like Reiki shape, than it does a traditional psychotherapy. But then when somebody comes out of that shaping and is kind of more able to verbally process, then we can go back into some more of the like what showed up for you and what was there material. So yeah, it's different.
Yeah, and you both touched on something that's really significant to medicine sessions, which is being able to, being in attunement with the client, and then being able to track what's happening in the client's experience. I would love it if you could both share, how are you tracking what's happening, especially because you can't use necessarily the same tools you use for tracking when the client is in normal consciousness, when they're in a non-ordinary state, and then how are you also tracking what's happening in your own system? Whoever would like to go first.
Yeah. Well, I think this really speaks to the importance of knowing oneself very well, intimately, if you are embarking on doing this work. If anybody has ever worked with a very sensitive client or a sensitive patient in traditional psychotherapy or other modalities, you'll know that they can pick up on very small things, the way that you use your breath or sigh or a facial, like an emotion or a facial expression. And so what we can recognize here in this work is that folks are very sensitive. They're in an incredibly sensitive and vulnerable and suggestible state. And so it's really important that we are aware of ourselves more than ever if we're doing this work. And so how are we typically tracking ourselves? And it's usually through, recognizing the breath. How are we breathing? How are we feeling in our body in this moment? Is there tension in our muscles? Is there tension in our joints, right? How are we feeling? What are we feeling in the body? What thoughts are emerging right now? What emotions are emerging right now? All of this matters so much. You'll hear facilitators over and over again talk about how if they brought something into the room, a particular emotion, a stress, a tension, or a memory, how often the participant will pick up on that. And it may even affect their journeys. This happens a lot in ketamine journeys, where a person is holding an image or a thought or an emotion, and they'll emerge from their ketamine session and say, I don't know why, but I was just all of a sudden, kind of bereft with this particular emotion or this particular visual. And it's happened many, many, many times for me, enough that I know it's not coincidence. And so I'll say that, again, it's very important that we are aware of what we're bringing into the room and that we're tracking what's happening inside of us.
I have the perfect quote to offer here that's in this realm. I've been reading it to my clients lately. It is from Bayo Kumalafe, from the podcast episode that I would highly recommend, that Beckley really does kind of use this sort of this lens, but it's the Emerald, the revolution will not be psychologized, with Bayo Kumalafe. And they said, emotion is not ours. It's not a brain phenomenon. It's a territorial phenomenon, and it enlists bodies in how it comes to matter. Emotion is not ours. It's not a brain phenomenon. It's a territorial phenomenon, and it enlists bodies in how it comes to matter. And I feel like Karina's speaking to that, because pretty much I feel like that's a fancy way of saying the vibes are off. And you can feel when you walk into a room, the quality of somebody's emotional experience. And in the same way that we co-regulate with other bodies, we also co-escalate. So the therapist is very, very responsible. I'll never forget when a mentor, who's also a psychedelic therapist, a mentor of mine, told me, yeah, are you ready to have to live a pretty bougie lifestyle? Because you're going to have to continue with your therapy. You're going to have to get your body work. You're going to have to do your meditation practice and your yoga practice and your spiritual practice, with a lot of discipline, all so that you can finally attune to those territorial phenomenon of emotion. And so that's happening for the therapist. It's just being able to, it's having witness awareness of what is happening. Oh, something happened. That's, I check in with the client now. And then for the client, having a long relationship prior to therapy, the longer the better. Also that both of you are able to attune into oh, that feels different, that feels significant, that feels new. And you're in that space together. Yeah, could say a lot more about that, but thanks.
Yeah. And how do you know, and this question is for both of you, how do you know when you need to intervene? What are you tracking for, and what are those signs in clients? And maybe there's sort of common signs, that you're looking for when you need to intervene, or maybe it's dependent on the client. But when do you know when to intervene? And then what kind of interventions, are you most commonly using?
That's such a good question. Yeah. I'll just say, yeah, I think this is a very important part of the learning process, with Beckley, because I think this is a place where some facilitators will, or practitioners will overstep, will kind of and interact with the client, maybe at not the best timing. So I do think a lot of that occurs from your own work, and then just deeply knowing the client and messing up prior to the medicine session, and then repairing that point. Yeah.
It's hard to know exactly when to intervene. Even those who are highly experienced may intervene too much or too little. And to Danielle's point, it's important to have a strong, trusting relationship there, so that we can kind of test it out in the medicine session, and the participant can test it out. So what does it feel like to receive therapeutic touch, right? That might be one way that we intervene. And what does it feel like to withdraw therapeutic touch? Have we, in preparation sessions, talked about breathing resources, right? How might we breathe normally? How might we breathe if we're feeling like we are experiencing tension or discomfort or distress? And how can we co-regulate our breathing? And so knowing when to intervene is sometimes a test. So we're testing it. And we might just do something like a little nudge. Hey, I'm here if you'd like some support, if you'd like some therapeutic touch, and we will practice that. We might just say something as simple as, take a deep breath and breathe. Or is there anything I can help you with in this moment? And we also want to give participants permission to completely wave us off if they don't need us, right? So I often tell people, if you hear me checking in and you're deep in process, don't feel like you need to respond to me. You can wave me off, you can give me a thumbs up, or just put your hand up, or do nothing at all, and I'll check in later.
Yeah, and oftentimes you work on teams when you're providing medicine work, and there might be other clinicians there, there might be other support systems that are in the room. What role do those other folks play in the care and sort of the interventions and providing support for the client, but also for you as the therapist?
So are you asking, Deb, about the co-therapist in the room with us?
Yeah, co-therapists. Sometimes you have other supporting folks on your team, like nurses or doctors. How does that play into the care?
Yeah, so for me, it's really important that each participant is familiar with anybody who is on the care team. So certainly if we're bringing in a co-therapist, that they have met the co-therapist, that they have good rapport, that they feel safe with that therapist, and they feel open and ready to tell me if they have any problems with those particular people. It's not uncommon that we would bring in a co-therapist for sometimes for clinical trials, just to serve as a co-facilitator for the dosing session. And so we want to make sure that the participant is aware of who that person is. And if they don't, they don't feel like they've established rapport and trust, and we need to switch that person out, and we definitely want to be open to that. We want them to have met the physician on staff, any medical assistants, anybody who they are going to come in contact with on the dosing day. They should have at least met once and said hello. And those folks need to be trained in not just trauma-informed care, but understanding that the participant is in a fairly sensitive and vulnerable state, and will be for the entirety of their time with us. And so that we're having an open discussion with the participant about how they're feeling about those folks.
Yeah, I definitely say that if you're working with a co-therapist, you want to also have the depth of relationship as deep as possible with that person prior to the dosing session for the client. Same thing, you just want to be attuned to them so that you're providing the best possible support. The other thing that comes up here is like when you're working on just like a care team in general, just like how expansive that care team may be, and knowing that when you're going into like psychedelic therapy, you're kind of agreeing to depth of relationship and with everybody involved. So for example, I've had like pretty long conversations with clients' doctors, especially in like end of life sessions, for just like making sure that we're kind of on the that our treatment plan goals are complementary to each other. And then also working with folks who are working with like craniosacral therapists or acupuncturists, traditional Chinese medicine providers. I do a lot of adjunctive work. So people who have a regular psychotherapist that they're seeing weekly. And then they're seeing me for ketamine work. So we're in conversation. We're pretty consistently checking in, again, making sure that our treatment plan goals are complementary and supportive of one another. And then that we have each other's contact information at the top of the page when we're in the dosing sessions if we need anything. So yeah, there's definitely like a large care team component to doing this work. Mm-hmm.
It's not uncommon for us as psychedelic facilitators or therapists to have phone calls with the ancillary care team or with their primary care treatment team, Zoom calls as well. In longer treatment modalities like ketamine-assisted psychotherapy, where we might be working with somebody for 6, 7, 8 sessions, I often invite the participant or the patient to be involved in those meetings. Sometimes all the time I invite, but they don't always take me up on the offer. I always invite the psychotherapist to come to the clinic and see the environment in which their client is going to be working. And I've had one person take me up on the offer to actually come in and sit in on the session because it felt clinically appropriate. And that actually worked really well. And so we can do, we can have no contact with their primary treatment team if that's what the participant wants, all the way to bringing them into the session if that's clinically appropriate.
Yeah, thank you. Thank you both for sharing. And one final question before we move to our Q&A portion is, how are you taking care of yourself during medicine sessions? Medicine sessions are long, a lot of materials coming up. You both mentioned how, you're having to track, what's happening in your own system that may emerge. We might talk about sort of transference and countertransference that's happening. And everything that's sort of going on, beneath the surface in that system, in that session. So, and Daniel, you spoke to this a little bit, but how are you, what are some tips for taking care of yourself during medicine sessions, after medicine sessions? How are you preparing for those sessions? And maybe we'll start with Karina.
Yeah. So we ask participants to take good care of themselves prior to coming into a medicine session and throughout the treatment time. I like to call it a sacred time. I invite people to treat it like it's sacred. You made this decision to do something novel and potentially profound. And so why not take very good care of yourself and listen to what's emerging? So we ask people to do, the core 5 physiological and psychological benefits. And so those typically are proper sleep, proper nutrition, physical exercise, time in nature where you're allowing sunlight to hit your skin, and you're giving your eyes access to the sunlight as well, and interpersonal connection. Those are the core 5 or the big 5 that keep us healthy and happy as humans. And so we are not exempt from that as therapists and facilitators. It's important that we are also engaging in those activities. The interpersonal connection probably being the most important. In other words, having connection with folks who understand what you are doing in these rooms. And that is, it's important that we are seeking out other individuals who do this work so that they understand and they can validate for us some of the feelings or the fatigue that can emerge as a result of it. In more practically during dosing session days, it's also important that just like we're encouraging folks to wear comfortable clothes and bring in maybe pillows or blankets or something that can help you feel comfortable being seated for 3, 4, up to 12 hours in LSD sessions. The same is true for us. So we want to make sure that we're well taken care of because we are caring in a very deep and profound way.
Mm-hmm. Yeah, these are great. I'm glad that you asked this question, Deb, because I feel like a common thing that's been happening in my sessions, ketamine sessions, is folks kind of expressing at some point some concern. They're like, just like, oh no, like when I feel bad that I'm taking up all this time. You must be bored. Like, are you bored? What are you doing the whole time? And so I'm like realizing that I'm needing to let folks in a little bit more on what's happening for me. And also working with that dynamic for them. Like, it's totally okay. Like there's a lot going on there relationally. Like you're allowed to be held and receive. But I do try to be, I've been trying to integrate more of the like, okay, so here's some things I might be doing in this space. One, I'm totally fine. Like I literally love my job. This is the best thing ever. Like I'm like meditating. Sometimes I'm doodling. I'm usually tracking like all of their movements and notes. If there's like, for example, they're in the depth of their experience, and they have like a somatic release of sorts. That could look like, for example, like, oh, these movements that are like expanding and opening. Then I'm going to like pay attention to that, track the time, take the song that's playing, so that when they integrate, we can go back and talk about it and see what was going on there. Or it's like if they verbalize something out loud, and I'll tell them ahead of time, like if you're verbalizing anything, I will write it down, and then I'm giving them these notes afterwards if they want them. Other things that I'm letting them know is that, you know, and this is something to do in preparation, that I'm a human and I will have to go to the bathroom probably multiple times throughout our long session. And let's practice that, you know, let's see what it's like when I leave the room. I've had a ketamine session before where like once I left, the abandonment wound, because we're in such a sensitive state, showed up, and it's like, okay, so we need to prepare even more. Like, how do we make sure, you know, that I'm just going pee and I'll be back. So you're planning for stuff like that. And then like Karina said, just like really tending to yourself. Having rituals before and after those sessions are important. One thing I'll name here too is that, you know, I have a lot of like, I just see where this field is going. And sometimes I think that we can almost think about these dosing sessions are like, oh my gosh, you can make a lot of money and you can like stack and do a multiple of them in one day. That's not true. You cannot do multiple of these in one day. You can do one. And pretty much that's all you're doing all day. Because of the preparation and the what you need to be regulated in order to be in that space, and just how much it takes. So typically before, I'm like resting, doing my practices, like Karina said. Afterwards, I'm cleansing, I'm taking the bath, I'm like shushing out everything that entered the body. And then I'm like writing more notes, like thinking about what happened in that session, like planning for integration, and just like deeply, deeply taking care of myself. So
thank you both so much. If anyone in the audience, if you have questions you'd like to ask Karina or Danielle, go ahead and pop them into the chat, or you can raise your hand. While we're waiting for some questions to go in, I have a question, which is, what's the importance of community and, you know, spending time with other therapists in terms of taking care of yourself?
Yeah, I think it's the most important. Like I said, people who do this work and understand what you're doing so that they can validate any stressors or fatigue or emotion that emerges for you. And sometimes it's difficult to recognize that, yeah, this is normal, or this is actually good grist for the therapeutic mill. You're feeling a certain way after a dosing session or after an integration session with a client, that probably means something. And so listen to what's emerging, and let's talk about it, right? So having people who care about you and love you. It's also really important to have folks who care about and love you that don't do this work, so that you can go back and feel like you're a part of something that feels, you know, happy and healthy and more normal than what can often become our new normal when we're doing this medicine work. Danielle and I are deeply steeped in this work, both personally and professionally. And so having folks who just are like outside of the medicine space that we can just go watch a movie with, or take a run, or have dinner, not talk about medicine, or not talk about clientele, or you know, kind of the deep stuff that can emerge, is also really important.
Yeah, that's great. Thank you. Okay, we have a question here about music. So do you play music before and during sessions? And maybe the bigger picture is sort of like, what role does music play, you know, in the therapeutic process? Whoever would like to go first.
Yes, we do play music. We almost always play music unless a participant requests that we don't. And that seldom happens. So playlists are usually curated for the arc of the medicine experience, and each medicine has a different arc. And so we are playing music before, that's usually more ambient music, and after, that's usually more ambient music, and then a playlist curated either by us and the participant, if it's appropriate and we have time, or in clinical trials by the PI or the sponsor of the trial.
And in our courses, we have a really sweet activity where folks are building a short playlist and then really sort of dropping into the experience of that playlist to see what emerges, thinking about how music has an impact on us, because it sort of is this outside factor, right? But it's deeply emotional or moving. And we have a hand raise here. Christine, if you want to pop on and unmute yourself, let us know what your question is.
Gosh, I couldn't press the buttons. Hi, I just have loved the last two. And I saw you guys the other session too, so I so appreciate your experience. This might be more of a comment, but Danielle, you reminded me when you were talking about taking the notes and actually noting the time and all that. There was a study that just came out of Sunstone Therapies where they had 3 raters. I mean, they had a bunch of raters, but they had 3 raters at a time watching video from it was the first 8-hour session of the psilocybin medicine session. And what was interesting to me is sometimes it took one person to notice, sometimes it took 2, sometimes it took 3. But what I didn't see was did they map it to the actual facilitator? And it would be curious to me to see, okay, if they took your data, for example, and mapped it to what these 3 raters saw, if it would map. And then also, of course, at least they didn't do yet, what the therapeutic, if there was a correlation between what they saw and rated and therapeutic benefit. So I don't know if either of you have a comment about that.
Oh, I mean, that sounds like a really interesting study. I'd love to see it. Yeah, I'm very curious to kind of go in depth as to what the implications are. Yeah, thanks for sharing.
Yeah, I think they primarily did it for training, but like I said, I think they should compare it with, the actual facilitator's notes and if there was therapeutic benefit. Yeah, I mean, I think if you Google Sunstone Therapies, I don't know what else you could Google, but you could probably find it.
Great, thank you.
We have another question here. So this is about something that you brought up, Danielle. I'm curious about the ancestral piece that influences a dosing session and the way in which our ancestors can be in the room or our lineage and what they want to work with. Question is, why does history come into the session? Why exactly does that happen? We're not even conscious of our deep ancestry sometimes, right? So how does that emerge when it's something that's not even known to us, which is something we often love talking about in our courses.
Yeah. So. Yeah, this is really good. So it's epigenetics. It's intergenerational, like pretty much like the proof that we have that we are carrying 7 generations before us and after us in our bodies. And yeah, so basically epigenetics 101 would be you take a worm, you traumatize it, you let that worm reproduce for 7 generations, and all the worms for the next 7 generations show or carry the genetic code of the trauma. And so humans are also experiencing that. And you see it in the room often, all the time, not just in psychedelic work. It's in regular psychotherapy where it's like, wow, this feels like an unprocessed trauma that was from mother, grandmother, grandfather, from wider events such as genocide, colonialism, war traumas that are just sort of like still being held, still being processed. And yeah, there, the cliche of I am my ancestors' wildest dreams is true, right? So when your existence gets to be this like place where you almost like you're working directly with whatever is being carried, and in somatic work, like this is a huge component to it. There's like very, very deep held material in there. So I'll stop there on that answer because I think we could, yeah,
make a whole webinar just about that. Karina, anything to add on that one?
Only that we approach it with curiosity, right? So we're listening for what's coming up in the body, what's coming up in the heart, what emotions are emerging, what thoughts, what visuals are emerging. And I often encourage participants to speak with their family members about their histories, about their generational histories, about generational traumas. And what they often find out is that their parents or grandparents endured traumas that they had no idea that they endured. And so this can sometimes open up a whole different avenue for psychotherapy.
Yeah. Another question here, when using medicines that have interactions with SSRIs, what or who do you use for support when you're titrating that medicine down prior to dosing?
This is back to the care team question. So I work directly with a prescriber currently who's an MD. I've worked with lots of different prescriber oriented folks who do like medication management. So there's always that sort of dyad occurring because as a LMFT, I'm not able to prescribe. So they'll have sessions with that prescriber and then talk to them about all their medications. That also supports working with like contraindications and any goals. Like currently I'm working with a client who is on Prozac and would like to titrate down. So we've increased her ketamine sessions to weekly, with the goal of having her reduce by the end of the year. And we've done that before. It's been effective. So that's that plan.
We've got 3 more questions. I think we have time to do them. I'm going to go a couple minutes over the top of the hour. Let's see. One is another kind of practical question for during dosing sessions. So what do you do with an emotion, with an image or a bodily symptom like cramping hands when it pops up? Do you try to dig deeper right away? Or do you wait until after the session? How do you manage to uncover its root cause?
It's really important that we are talking about what we will do when discomfort or distress occurs in a dosing session, and that we're talking about that in our preparation sessions, and that we are preparing people and rehearsing for what will happen when such things occur. So typically, a general rule is that we want to move people toward the uncomfortable material, and because there is often wisdom there. And we are helping people to tolerate that level of discomfort in the dosing session with help, with care and compassion, and that in and of itself can be curative or begin a curative process. So that's not always the right thing to do. And so we have to, this is why it's very important that we know the participants' history, especially their trauma history, because we may need to do what's called pendulating in a psychedelic experience, where we move people a little bit toward the discomfort and then move them into a neutral place, or even to a place that feels very comfortable. And if it feels like the experience is completely intolerable, then we'll just back off, because we don't want to risk re-traumatizing a person in a dosing session. But this also becomes grist for the therapeutic mill and integration session.
Yeah, thank you. This question is about, so I'll read it as it's written here. Can you speak to the balance you try to strike between following the contours of the client's own journey on the one hand and holding the frame of the space on the other, in relationship to allowing the client to, for example, move around, talk, draw, write, dance, etc., versus encouraging them to sit or in a meditative state? And I can think of all kinds of things that come up here with inner healing intelligence, preferences for how people process and move through experience, but also safety concerns. So
this one is hard to teach because it's kind of like a developed intuition. It also has to do with the relationship, right? So I'm like instantly off the top of my head thinking there are clients who seeing them move around a bit, talk, dance, write, even just like somatically express, that would be closer to meeting their treatment plan goals, because maybe they're a little bit more of a sedentary or a more like internalized person. They collapse, they are contractive or constrictive. And whereas like maybe another client who's like has like a higher pacing energy and maybe more of an ADHD sort of shaping, then like for them to be in a meditative, quiet, like pause space, that would be closer to their treatment plan goals. So it's like you're thinking about those shaping, so you can only answer this based off of like the client-centered response. And then also a lot of this does just come down to that like therapist taking care of themselves so that they can really know, like really be aware of the intuition, and also talking to the clients about like, I may have told you to be like to go internally at that point when you really didn't need to. Let's process that in integration and see, it's all grist for the therapeutic mill.
Mm-hmm. Thanks. One final question here. So considering the age at which the brain matures, and the person is named 25 as the age here, Can younger folks younger than 25, in the case here, an 18-year-old who's been struggling with depression, with attempted multiple suicides, would they be disqualified from something like ketamine therapy because their brain's not fully developed yet?
I think the short answer to that is no. In clinical trials, all the clinical trials that I'm aware of, you can be 18 years old as long as you qualify for the study, you can participate. And the same is true with ketamine. There are a handful of people in the landscape right now who are working with younger folks, adolescents, in ketamine, and there may be one or two papers in which folks have used psilocybin with adolescents. But because of exactly the reason that the nervous system and the brain is still developing, we tend to shy away from utilizing these medicines with younger people. We should note here, though, that these medicines have been used for thousands of years in indigenous communities, and they were used with children and adolescents all of the time. When and how, the community knew when and how to do that because they had longstanding relationships with the families and the children. They knew them since birth or even prior to birth. And so here, the lesson that we can take away is if we feel like we know the individual and that the medicine session has more potential to do good than harm, then certainly we can try. Ketamine is a reliable antidepressant and typically is utilized when folks are highly suicidal or coming to us for treatment-resistant disorders. And so I would have no qualms utilizing ketamine with someone who's 18 or older.
Thank you. And Karina and Danielle, thank you so much for this conversation. Every time we connect and we have these conversations, I learn so much more. I appreciate both of you. And we will close this conversation. I hope that all of you can join us for our next webinar, which is about integration, which we'll be doing soon. I think Sherelle can give us the date on that. And I will hand this over to you, Sherelle.
Sure, thank you. Kabir, while you put up the slides, I'll give you all some information on the next webinar. So we just completed the second of our 3-part series, and the next webinar will be on September 20th. You all should already be registered for it, and we hope you can join us live, but if you can't, we will be recording it and sending out recordings afterwards. And now I just wanted to close with a couple pieces of information about our upcoming fall cohorts. So we will be kicking off our fall cohorts of our Foundations for Psychedelic Assisted Therapy on October 9th. We're really excited. The seats are filling up quickly, and we'd love to invite you all to apply as soon as possible so that we can get you into the cohorts. The way that we structure the class is that it's 76 credit hours. That we teach through Zoom. This is a combination of group work, online pre-work, some of the assignments you'll do on your own time, and then you'll come together for the classroom experience, which are rich live discussions, quite like what we saw today, and then also small group work with your Communitas pod. I had the pleasure of completing our course as a learner because I'm also a student right now to become a counselor. So if you have questions about the learner experience, I'll drop my Calendly into the Zoom chat, and you can schedule a time with me, and I'd be happy to share a little bit more about my experience. And then the class goes for 21 weeks. So we stretch it out over about a 5 to 6 month period. And that gives you time to, one, lead your busy full lives, and then also to integrate that material and kind of have time to digest it and do the coursework and at a pace that doesn't feel overwhelming. So to go a little bit more into some of the theories and methodologies that we use in the course, we follow a couple of different educational theories. And so this really impacts the way that the class is designed, but we take a learner-centered approach, meaning that we learn from each other as much as we learn from the course material. So there's lots of opportunities to be able to share and to discuss. We have an embodied approach to learning. I personally loved the fact that a lot of our pre-work was to do visualizations, to do journaling work, to go out into nature, and really develop some of those skills that you'll be employing in your client work on your own. We take a relational approach, which is why we build so much community into our course. The classroom is flipped, meaning that you do a lot of your pre-work and reading outside of the classroom, and then your time in class is for discussion. And then we also take a constructivist approach, which is a term that Deb would have to define.
Really, we realize that all of our learners come with a wealth of experience to class, right? And so what we're doing is really co-creating the learning together, bringing together all of our experiences. Another way to talk about that is really, we take our faculty who you've had the chance of listening to today are obviously very, very knowledgeable, but they take an approach that's more like a guide on the side, similar to in therapy, where they're not directing where your learning is going, but they're helping sort of draw information out of you and guide you through your learning experience.
Yes, thanks, Deb. Some of the psychological approaches that we take are psychodynamic, somatic psychotherapy, transpersonal, and psychoanalytic. And then we feature, key theorists from psychedelic psychotherapy. So Stanislav Grof, Carl Jung, which, is beyond psychedelic therapy, and then draw from the works of Janice Phelps, Kylie Taylor, Frederick Fisher, and Amanda Fielding. We can move into the final slides. So here is an overview of our course content. The course is comprised of 6 modules. We start off by creating our communitas pods and going through liminality, working on developing resources that you'll be using as a clinician, and evaluating the PAT competencies. In our first module, this is where we focus on what it means to create an intentional practice. How do we be in right relationship with both ourselves, our clients, and then greater systems? And then we have a deep focus on the ethical considerations for psychedelic assisted therapy. And so that's a key component of that first module. In our second module, we go through indigenous uses of psychedelics and recognizing where a lot of the practices come from. We talk about the power of ceremony, and then we go through some of the mental models and belief systems that impact client work in psychedelic therapy. In our third module, we go through all of the contemporary research, we go through the main pieces of contemporary research and use of psychedelics. We talk about the limitations of research and just what this paradigm shift means for the field of mental health. In module 4, we start to go a little bit deeper into the internal experience. And so we are developing an inner awareness of all the power dynamics that are at play for you as a clinician when you're working with clients. And then we deepen into transference and countertransference. Module 5 is one of my favorite modules. Here we have an experiential module where you're able to practice some of the skills around preparation, holding space, as we talked about today, and integration by engaging in a cacao ceremony that we facilitate online. So module 5 is a pretty unique experience. And when you look at the course schedule, you'll see 3 days in a row that are dedicated to this experience. And then finally, in module 6, we talk about establishing a community of practice, further clinical applications, and then we close our container together as a cohort. We can move into the next slide. Here's some of our wonderful contributors to our course. We're really lucky to be able to work with researchers and clinicians all across the field through the Beckley network and alongside of our faculty members. And I think that's all the information I need to share with you on the course.